Good morning, everyone, and welcome. On behalf of the American Academy of Nursing, it's my great pleasure to welcome you to this public forum this morning focused on critical conversations for advanced care planning for people with life-limiting illnesses. This event is part of the American Academy of Nursing's Raise the Voice campaign, a campaign that brings evidence-based and practical solutions to many of the country's most vexing healthcare problems. My name is Virginia Tilden. I'm a nurse and a fellow of the American Academy of Nursing. And in 2010, it was my great privilege to chair the Academy's task force on crucial conversations for improving advanced care planning. The Academy appointed this task force following national concerns about how to improve consumer choice in advanced care planning. The task force produced a policy brief that is in your packets entitled Advanced Care Planning, an Urgent Public Health Concern. And this policy brief contained 4 recommendations: that the 1991 federal law called the Patient Self-Determination Act should be updated and improved, that electronic medical records should clearly and prominently document a patient's preference for treatment in the event of serious illness, that the extensive time that clinicians and sometimes ethics committees devote to really good advanced care planning with patients and their families should be compensated, and that the education of physicians and nurses and other professionals who often are involved, such as social workers and clergy, should contain much more content on how and why and when to do advanced care planning so as to be in tune with patients' values and preferences for the level of aggressive treatment they want or do not want. Today's program brings national experts to help us better understand what is meant by the term critical conversations. Perhaps in no other area of healthcare decisions than those surrounding life-limiting illness is there more public anxiety and confusion. Critical conversations like those you will hear today can help reduce both. Now, let me tell you about the plan for the program. We will first hear from Mr. Bill Novelli, who is a professor at the McDonough School of Business at Georgetown University and the former CEO of AARP. Mr. Novelli will report on research findings about public knowledge, perceptions, and behavior pertaining to advanced illness. These data have been compiled by the Coalition to Transform Advanced Care, known as CTAC. CTAC seeks to ensure that all Americans with advanced illness receive comprehensive, high-quality, person-centered care that is consistent with their goals and values and honors their dignity. Following Mr. Novelli, we will have 2 panels, each with a distinguished moderator who will introduce the panelists. You have the panelists' bios in your packets, so introductions will be brief. Each moderator will converse with the panelists and then engage those of you in the audience and those on the webcast in a conversation on the topic. Now, I'll pause here to speak to those who are with us today via the webcast and ask you to be part of the conversation with the panelists when the time comes. And to do that, please send your questions to the following email address. And make your questions quite short because they need to be transcribed and brought up to the moderator. But here is the address for your questions. It's an email address, questions@aannet.org. And when the time comes, I understand that that email address will also be projected on the screen. The first panel focuses on the experience of people with terminal illness and the nurses and physicians who care for them. This panel will help us understand the challenges that patients, families, and clinicians face. The panel will be moderated by Jackie Judd, who is Vice President and Executive Producer for Multimedia for the Kaiser Family Foundation. The second panel focuses on evidence-based solutions for improving planning conversations. Panelists will discuss best practices and effective models for focusing on patient choices for the quality, not just the length, of their lives. The panel will be moderated by Jordan Rao, a correspondent for Kaiser Health News. And again, we will ask you to participate in the conversation with your questions. Finally, after the second panel, Mr. Novelli will make concluding observations and remarks to help us put closure to this morning's conversation. As an outcome of today, the American Academy of Nursing and all of us on the program hope you find that the forum stimulates your writing and your future conversations with others. The Academy would be very pleased to help you to extend today's conversations to the communities where you work, whether in public media, public service, government, the insurance industry, or other key communities and audiences. You have a packet of resources to get you started. We invite you to request additional sources of information from Kat Piscatelli, the Communications Manager at the Academy. Before we begin, and on behalf of the Academy, I extend warm thanks to the following foundations for their generous support of this event: the Rita and Alex Hillman Foundation, the California Healthcare Foundation, the John A. Hartford Foundation, the Archstone Foundation, and the Jonas Center for Nursing Excellence. In addition, our warm thanks to the Kaiser Family Foundation for hosting this event in their Barbara Jordan Conference Center here in Washington, D.C. And now it's my pleasure to introduce Mr. Novelli. Mr. Bill Novelli is a nationally recognized leader in social marketing and social change. Over his long career, he has managed programs in cancer control, diet and nutrition, cardiovascular health, reproductive health, and infant survival, among others. He is the co-chair of the national organization I referred to earlier, the Coalition to Transform Advanced Care, or CTAC, which is dedicated to reforming care for people with advanced illness so as to include the kinds of conversations we will be talking about today. Mr. Novelli is a professor in the McDonald School of Business at Georgetown University, where he teaches in the MBA program and has created and leads the Global Social Enterprise Initiative. From 2001 to 2009, Mr. Novelli was CEO of AARP, a membership organization of over 40 million people 50 and older. During his tenure, AARP achieved important policy successes at national and state levels in health and financial security for older Americans. Mr. Novelli is the author of 2 books, 50 Plus, Give Meaning and Purpose to the Best Time of Your Life, which I plan to buy today, which was updated in 2008, and Managing the Older Worker, How to Prepare for the New Organizational Order, written with Peter Capelli, published in 2010. Welcome, Bill, and thank you for leading us off today.
Well, good morning, everybody. Ginny, thank you for that kind introduction. Don't buy the book. I'll send it to you. I'd like to begin by congratulating and thanking the Academy for having this very important conversation today. It's not a surprise to anybody in this room that we live in challenging times. And I'm talking about the enormous national and international debt and deficits, climate change uncertainties, chronic under and unemployment, growing levels of obesity and other risk factors that are reducing quality of life, and an aging population that's putting pressure on our health and financial security and other systems. And many of these challenges are interconnected. And today we're here to talk about advanced care planning and decision making. Now, with the aging of our population, indeed the world's population, more and more Americans are living with serious chronic diseases, and more families are facing difficult caregiving and related decisions. And all this is accelerating as the boomers come into their older years and as pressures on family and institution and government finances continue to build. Inadequate advanced planning fragmented care systems, poorly treated physical and emotional distress, heavy strain on caregivers and support systems, and lack of communication among providers, patients, and families are all typical. And clearly, we need to address advanced care planning and decision-making much more effectively than we have in the past. Now, I'd like to talk about the communication part of this big issue. And as you heard, I co-chair the Coalition to Transform Advanced Care, or CTAC, of which some of you are members. We're a growing alliance of patient advocates, provider groups, insurers, clinicians, faith-based organizations, and academicians. And we're all committed to reforming advanced illness planning and care by empowering consumers, changing the health delivery system, improving public and private health policies, and enhancing provider capacity. And now we're far enough along so that in 2 weeks we're going to announce CTAC to policymakers, to the public health and medical communities, and to thought leaders. A few months ago, CTAC held a conference to review what is known about public knowledge and perceptions and decision-making about advanced planning and decision-making. And we looked at the available research, and we identified gaps where greater understanding is needed. And I'd like to share with you a few key findings from that review. First of all, there does not appear to be a common language or understanding about these issues, and different meanings and interpretations are often given to the same words. For example, few people know what palliative care is, and serious illness connotes terminal illness to 18% of adults 25 and older, while advanced illness signals terminal illness among 36% of the same population. Second, most of the studies that have been done start from the researcher's point of view. You know that old marketing adage, start with the consumer? Well, most of the research starts with the researcher's point of view, with a defined topic, such as advanced directives, palliative care, and end-of-life care, rather than starting with that health consumer and her concepts and vocabulary. Next, emotions are deeply embedded in how people perceive the need for advanced planning and the eventual patient and caregiver decisions that have to be made. There's strong evidence that people want information to be presented in positive ways. They respond to anecdotes and stories. And especially with boomers, those lovely boomers, age is not so much a relevant frame of reference for these boomers as are future opportunities, however limited, rather than thinking of decline. Also, while people certainly worry about old age and about illness, there's a reluctance to think about a later stage in life when they may be dependent or ill. There's resistance to thoughtful discussion and instead an orientation towards vague, brief conversations. To make things even more complicated, this disparity in vocabulary and meaning also exists among health professionals. And no surprise, there seems to be frequent miscommunication between clinicians and their patients and families. Now, what can we do about these multi-layered communication problems? For one thing, we clearly need additional research so that we can better understand the decision processes that people go through, including both health consumers and health providers. And as I said earlier, we need to focus on the audience, not on our own concepts and our own language. Now, one issue that clearly needs more study is cost. There's some evidence that patients and families pay very little attention to the costs of advanced illness to Medicare and to the healthcare system. But they do care about individual and family costs, and the toll is very high. They don't want to leave their families in debt, and they do want to leave something of a legacy. And we should explore potentially effective communication strategies, such as storytelling and narratives. And in addition, we need to understand the differences in perceptions and vocabulary and decision-making among different ethnic and racial groups, because these differences do appear to be significant. Now, I've only touched on the communication issues, and they're just one part of the complicated tapestry of advanced planning and decision-making. As our panelists today discuss the clinical side, models that work, and other areas, let's think about our own perceptions, about our own understandings, and those of people we know. We all have personal stories about family and friends. I believe we're making progress, and we're going to make much, much more. The time is right for progress and for change, and that's why I'm involved with CTAC. We're never going to solve or cure the problems of mortality, but we can move toward a better place, where Americans make better decisions that are connected to their goals and their values, and have a greater understanding and acceptance of the realities of disease and death. Thank you very much.
Thank you, Bill, for leading us off. Now, to get us started on the first panel, I would like to introduce Ms. Jackie Judd, the moderator of the panel. Ms. Judd is Vice President and Senior Advisor for Communications at the Kaiser Family Foundation. She joined the foundation in 2003 as a Senior Visiting Fellow. Her current responsibilities include the development of multimedia content for Kaiser Health News and the foundation, overseeing the foundation's information technology group and video production unit, and serving as a technical advisor to the foundation's international broadcast partners in the development of news content. Ms. Judd is a former longtime broadcast journalist known to many of us, and she's covered a range of issues, including politics, healthcare policy, and Congress. She was with ABC News for 16 years, as a correspondent for World News Tonight with Peter Jennings, Nightline, and Good Morning America. At National Public Radio, she was a news anchor and co-host on Morning Edition and Weekend All Things Considered. She's a former CBS News radio correspondent. Her honors are many, and they include National Emmy Awards, an Edward R. Murrow Award, the Joan Barone Award, the David Bloom Award, a DuPont Award, a commendation from Women in Radio and Television for a series on women's health issues, and an Overseas Press Club Citation of Excellence. Welcome, and thank you, Jackie, for moderating our first panel.
Thank you, Jenny. Thank you. Do you want to all come up? Good morning, everyone. And thank you for having me here. I'm really delighted and pleased to be a part of this important conversation. As Jenny said earlier, you have the bios of our panelists in your folder. I really encourage you to read each and every one later on, because these are committed, fascinating, and accomplished people. And I don't always say that before introducing a panel. And first, I would like to introduce Amy Berman, who is a registered nurse and a senior program officer at the John A. Hartford Foundation, which is helping us put on this event. She's long been involved in issues related to geriatric care. Amy is also living with stage 4 breast cancer. She has written extensively about her experiences within the healthcare system. Teresa Brown is an oncology nurse in Pittsburgh. She, too, has written extensively on the challenges of nursing and the nurse's role in the care of seriously ill and terminal patients. And you may be familiar with her writings in the New York Times blog or column? Blog. It's called Well, and she does it well. And Manoj Jain is an infectious disease doctor. He also teaches at the Rollins School of Public Health at Emory University. He too writes for the Washington Post, among other publications, on a range of issues, including end of life. We are going to hear from each of these speakers in the order in which I introduce them, and then after that we will open it up to a conversation with you in the audience. Amy?
Thank you, Jackie. Good morning. So as Jackie just described, I live with stage 4 breast cancer. There are only 4 stages. What that means is that the cancer has spread in my body. It also happens to be in my lower spine. This is what they call a terminal illness. This is an illness that is not going to go away. It is a one-way street. But what I'm here to talk about is the patient's role, my role, and the decisions that I make. And I've been very transparent about the journey that I've gone through since engaging with the health system and since getting the diagnosis. And at the very beginning of this, I went to see 2 very different providers. One provider wanted to throw everything at the disease. He wanted to do very intensive chemotherapy, as intensive as it can be, then do a mastectomy, radiation, followed with very, very intense chemotherapy. And I asked him, is this going to cure the illness? He said, no. He said, but, maybe we might get you to live a little longer. You can't excise the illness once it's spread through your body, so doing the mastectomy also would not have had benefit. The other provider suggested that we go with a palliative approach. Now, I'm very fortunate in that I'm a nurse and I am an expert in the field of geriatrics, and I have the ability to call up many wonderful people in this country. I was very well poised to make this kind of decision. It is an informed decision, and I have chosen an approach that really is trying to maximize my good health days. At this point, I should say that tomorrow is my birthday, and actually I'm not going to celebrate my birthday tomorrow. What I am going to be celebrating is that I'm coming up on 1 year since the diagnosis. And because of the decisions that I made, it has been a wonderful year. I mean, I'm in front of you. I'm not going to conceal anything. People can ask me any questions, and many people do. But it has been a great health year because of the decisions that I've made, and the likelihood is that I will live as long, if not longer, than having made the other choices. It would have been a bad year. I would not have been working, enjoying my family, my friends. So the decisions would have been very different. And if there had been a longer-term opportunity for having some kind of health improvements out of it, I would have made those decisions. I'm not giving short shrift to myself. I'm also not advocating that everybody should make my decision. But, it's important that the consumers have the right to make the informed decision. And that is what's missing. We have consumers who have disclosures when they buy a house and great consumer protection laws. Consumers of health, particularly in serious illness, and it does not get more high leverage than this, they don't have the ability to know everything about not only their diagnosis, but what's the course of their illness. What is it expected to be? And they also don't know necessarily about all of the different choices that they could make. They're presented with certain choices, and that's it. The first oncologist that I went to said that this is the treatment that he gives to every one of his patients. He said, that's it. This is what I suggest. All of my patients, whether they're stage 1, 2, 3, or 4, this is what they get. That's one-size-fits-all healthcare. It does not fit with my goals. So I'm here really to advocate as a voice for the consumer of health and to share my own experience going through this. It's been a magnificent year. I wouldn't miss a single day of it. I feel well. I'm doing well. I've got great function. I don't have pain. All of the good things that I would possibly want. I'm trying to make my trajectory good health for as long as possible, and then what I view as really kind of the bad health for as limited as possible. If I had made the other choice, instead of doing good health for as long as possible and trying to limit that bad health, I would have immediately dropped to what I consider to be bad health days. I would have had stomach problems, vomiting. I would have had to leave work. I would have been tired. I would have had ongoing problems with pain in my fingers, my toes. It would have made it difficult for me to walk. I might have gotten what they call chemo brain, confusion. These are all things that are the norm that many people experience, and they experience them for good reason, because they're going to get some kind of benefit later on. But for people like me, I'm not likely to get that benefit. And for me, I had to make the best choice. I can't say that it's the choice that everyone should make. I am completely supportive of anybody's choice in this matter. All that I'm saying is that the consumer needs to be the one that's informed, and the consumer needs to be the one that's sharing their thoughts and feelings on what is the right goal for them and what's the right treatment for them. So I'm very appreciative to everyone for trying to convey these messages, because patient-centered care relies on that patient. Decisions have to be made by that person, and it doesn't get any more important than this. 2.4 million people die every year. Well, so it's a common experience, and yet it's uncommon to have these conversations. I'm hoping that that will change. Thank you.
Thank you very much. Teresa?
Well, first, congratulations to Amy for a wonderful year. That's fabulous. So I also have a story to tell as a nurse in the front lines, people say working in a hospital. And this is a fairly grim story, and the point is to spell out these kinds of situations. What Amy calls bad health days can actually happen in the hospital when we're trying to keep people alive. So a little bit of background. This was a patient roughly my age, I'm 46, with school-age children, had a diagnosis, needed to get a stem cell transplant. And then for those of you who don't know this, transplant itself can actually have side effects that can be deadly. So it's not a procedure without risk, and people know that going into it. I mean, we're honest with them about that. But I had this patient, and we all love this patient. He was a great, great guy. And I had this patient one weekend, and the physician who was rounding that weekend said, wow, stage 4 GVH, there's just, because the problem, the side effect is called graft versus host, so we abbreviate it as GVH. So he said, stage 4 GVH, there's nothing we can do for that. And I said, has anyone told his wife that? And has anyone told him that? And I was pushing for that to happen. Well, and I respect this doctor tremendously. He said, I'm just here for the weekend. I don't want to get into this kind of conversation. And it didn't get brought up. So what happens, and this happens over and over again, this is not a unique situation, is we start throwing everything we can at this patient. Maybe we can use this drug. Let's try this drug. Let's do this. Let's do that. And this man lived for several weeks more. And the condition that he had causes your, at its most severe form, causes your skin to actually slough off in areas. It's extremely painful. It's like having a severe burn on parts of your body. And also is disfiguring if it is on your face. So we needed to change the dressings on these areas of his body, which, as you might imagine, for a burn victim is extremely painful. It got to the point where his breathing status was so fragile that if we gave him appropriate pain medication to make changing these dressings tolerable, he might stop breathing. And it took a team of us to go in and do this. And I remember another nurse and I doing this together, and the look on her face afterwards. And she said, that man has, it's like 3rd-degree burns, and we are doing this. He doesn't have any pain medication. There's nothing. And the anger on her face, and it was very, very hard for all of us. So I think, I don't want to elaborate more on the story. I think the story speaks for itself, but the emotional costs in a situation like this, I mean, first of all, is that how he wanted to die? I doubt it. Is that how his wife wanted to spend her last time on earth with him? I doubt that too. Maybe it would have been if he had been given the choice, but my sense is he was never told there is data that shows if you have this level of side effect at this problem, we cannot fix it. We cannot do anything about it. And that's really my message today, is that in the hospital we see situations that we cannot fix. I mean, we just can't. And to witness this slow decline it's very hard on families, and it also takes a toll on the staff. And that's been well documented, that nurses suffer what's called moral distress and compassion fatigue. But what it really comes down to is we need to be here to help people and to be able to recognize there may be a point where helping them means we don't keep trying to fix them because we can't. And then we come to them with what we have, which is compassion and comfort and help of a different kind. Thank you.
Thank you.
I want to talk about this topic from the doctor perspective. Amy, happy birthday. we were just talking earlier. Amy and I went to the same high school, Needham High School, in Massachusetts, and we didn't know that. And she was in the same class as my older brother. Oh. So what a pleasure. So our end-of-life conversations happening. And as a practicing doctor, I would have to say, no, not often enough. Just a few weeks back, I saw a patient, an elderly patient who had severe dementia, congestive heart failure, emphysema, was in the hospital, was in the nursing home, and was admitted to the hospital. There was no advance directive. And came to the ER, was intubated, was sent to the ICU, and then I was asked to see the patient for sepsis in the ICU. This is often the rule in many places, not the exception. And we need to understand that this is the wrong way of practicing medicine. In 2008, there was a study done from Boston, and in terminally ill patients, what they found that 2/3 of the patient had not had a conversation about end of life. These are terminally ill patients at a baseline level, which was a few months before their death. What are the implications of this is something that we must keep in mind. They're enormous. The patient that I saw stayed in the ICU. She suffered for 2 weeks and then died. It could have been different. 80% of us want to die at home, but majority of us end up dying in the hospital, often suffering or strapped to the ventilator and so forth. And we know that end-of-life conversations have a major impact on patients and families. And they improve the quality of life, not just of the patient, but also of the caretaker. Decrease ventilation time, decrease resuscitations, early hospice use. So I want to ask this critical question. Why are end-of-life conversations not happening from a doctor's perspective? And I want to provide 4 possibilities. The first is that we have lack of training as doctors. Doctors are trained to save lives, not to facilitate death. That's the way the old paradigm was. We need to change that. And too many doctors, including myself, often think of death as a failure, a poor outcome. We need to also change that way of thinking. Simply, a lot of doctors don't want to talk about end of life. I can give you one example. Mike Vanata was one of my patients. He had terminal pancreatic cancer. I talked to him about how he felt when he was told his cancer diagnosis. And his eyes widened and he said, I wanted to beat the bleep out of the doctor. And I said, what? And he said, the doctor came in, looked at his papers, the pathology report was there, he said, this is terminal. And he sort of walked out. Didn't have much more to say. We need to train and teach doctors how to talk about end-of-life care. So the first thing I think we need to do is to provide training. Why don't end-of-life conversations not occur? Second, it's a very difficult conversation. Recently, a close friend of mine who had T-cell lymphoma died. And I'm writing a piece about him in this Tuesday's Washington Post. And one of the most difficult conversations to have was about his prognosis. How long did he have to live? And what we notice is that's a huge problem amongst doctors. Doctors tend to sort of overshoot the years or months that patients have to live by 2 to 3 folds. And those doctors who have a good relationship or a doctor-patient relationship, close relationship, tend to do that more often. And so those are some things that we have to keep in mind. Why don't conversations occur? Well, they're very emotionally trying as well. Each time I talk to a patient about end of life, I also think about my own mortality. And those are conversations that doctors need to learn and train to do. And culturally, I think we are at times inept to have these conversations. In a Western society where we focus in on the youth and immortality, we have to sort of at times look at what happens in the Eastern culture. And I talk about this in the article. And my grandfather, who's 93 and lives in India, has been preparing for death. He's sold his house, sold all his possessions, except for the essentials. And he's preparing for death almost like an expectant parent prepares for a new child. Remember that when we filled up our tanks of gas and we had an overnight bag ready? And that's how my grandfather is doing that at age 93. What's the third reason that we don't do end-of-life conversations from a doctor's perspective? You know, our payment system in healthcare is misaligned. We reward for procedures, not for conversations. There is a financial disincentive for doctors to sit and talk to patients. And end-of-life conversations require time. And I want to finish with the last one, which I think is probably the most critical reason why end-of-life conversations don't happen among doctors. And it's our healthcare system. Think about this. Our present healthcare system focuses on curative care model where the goal is to treat diseases. Sometimes, yes, we do talk about the preventive care model where the goal is to prevent illness and to promote wellness. Rarely do we think of our healthcare system in a palliative care model where the goal is to relieve suffering and to improve the quality of life. So curative care model, preventive care model, and a palliative care model. Think about those. So a good doctor must know when to switch from one model to the other. But a better doctor must know how to integrate these models. So a study from New England Journal last year showed why it was important to integrate. In patients who had metastatic lung cancer, 151 of them, what they did was they integrated palliative care with the curative care model. And what they found? The quality of life was improved, depression was decreased, and guess what? The patients lived 3 months longer. Amazing. We don't have to wait for years and years to make this happen. And this isn't a theoretical or an abstract idea. Gunderson Lutheran Hospital in La Crosse, Wisconsin, has done tremendous work on this. Just to look at the results, it's amazing. 90% of the people in the town have an advanced directive. That's twice the national average. Patients at Gunderson Lutheran spend 14 days in their last 2 years in the hospital. This is compared to 40 days in most cities like New York, Miami. And the average cost for those last 2 years in La Crosse, Wisconsin, is $18,000 compared to $60,000 in some of these big cities. What a difference. So, I want to finish up by saying, from the doctor's perspective, we can do a great deal in the end-of-life conversations. What needs to be addressed is the lack of training, the difficulty of the conversation, the misaligned payment system, and to focus on the models of care, the palliative care, and not just on the curative.
Thank you very much,
Thank
all
you.
of you. Amy, I'd like to start with you. You encourage consumers to be informed, be able to make wise decisions, and yet it happens in this environment when they're at their most vulnerable. They've just received a frightening diagnosis. So one, what is your advice for consumers, for patients, to make better decisions for themselves? And what is your advice for patients who may be older, may be quite frail, who don't want to be empowered to make a decision? They want to be told what to do.
You know, I'm kind of thinking about Manoj's words that you know, the physicians want to be heroic. You know, they really want to do the right thing. I don't think any member of the healthcare team wants to do the wrong thing in any of this. But not having that conversation, you know, really will mean that the care will be aggressive. I mean, that's the reality. I mean, I think that the example that Teresa provided is a great example of that. When people are at their most frail and most vulnerable and they're being told reality, the question is, if they aren't told, what will be the outcome versus if they are told, even if they're at their most frail and vulnerable. Having that conversation gives them an opportunity. It gives them a window of opportunity if they not only understand the diagnosis, if they understand kind of the course of illness. In my case, 40% live to 5 years. I have the most aggressive form of breast cancer, but that includes stage 1 through 4. So for me, at stage 4, my prognosis is worse than that. That's a lump, you know. And when you were saying that they kind of, what did you say? They overshoot. They overshoot this by 2 to 3 times. I was given the 40% for 5 years, which is not specific to stage 4. So I don't actually know. There isn't really good literature on what my prognosis is. But let's just say it's not a long prognosis in all likelihood, you know. But it's possible it might be different. I was just as frail and, you know, just as distraught, and had complete presence of mind to write everything down like a good consumer should, to make sure that I could go back and have continued conversation to explore, to find out as much information as I could and seek a second opinion. You know, all the things that one would do any other time in healthcare. You know, these are the same things. If something is major, these are the things that you should do. But frailty and weakness on the part of the consumer it's an excuse that the healthcare system overlays. It is an excuse and a barrier. I've seen culture being used as a barrier. An individual is going to have their own thoughts on what their own healthcare trajectory is going to be. And while it may be true that there are people who are going to say they don't want to know, you have to ask them first, do you want to know? Mm-hmm. Because ultimately, you know, that may create a different pathway for how that conversation goes. And I can respect that too. But you have to ask the question, and it's not being asked. And from there, the information has to be given fully, not just on the diagnosis, but what the course of that disease is going to be like, and what the range of treatments are going to be, and what the quality of life could be with those different choices. These are very big decisions.
Teresa, in your columns, your blog postings, you describe yourself as being very much an advocate for the patient, not an extension of the doctor. That's put you at odds with some doctors along the way. So what I'd like to know is, did you reach a meeting of the minds with any doctors in terms of how you as a nurse should be treating the patient, talking to the patient, dealing with the patient, maybe even advising the patient? And if you did, how did it work out well?
Gee, I'm sorry to say the answer to your question is no.
That's why we're all here.
Okay. We have physicians who are fabulous at having these conversations, and of course, with them, it's not even an issue of working well. It's just this is what they see as part of their role, and they're good at doing it. But my experience has been, even talking individually or going through different kinds of channels, and having our ethics committee come up and just talk with the nurses about how could we approach physicians about these issues, and it doesn't go anywhere. So
And did you feel like you were in the minority as a nurse? Did other nurses feel, as you did, that you were there as an advocate?
Yes,
Okay.
definitely other nurses feel that way. And definitely there's always a broad spectrum of opinion on the floor among the nurses about, should we give this person more chemo? There are definitely nurses who feel we should give everyone every single possible treatment we can. And so it's not that there's a unified attitude among the nurses, but there is a lot of frustration, especially with patients like the patient I described. It's tremendously difficult, and it's not considered part of our role to go in and have those conversations with people or to bring those issues
I think
up.
one doctor told you, you see a snapshot of a patient, and I, the doctor, see the entirety of the patient.
Yes. Right.
Something to that?
Well, yes and no. I mean, yes. Say they've been treating someone for 10 years, they know their history, they know their personality, they know what's going on in their family. That's definitely true. They will always know more about that patient than I will. And what nurses bring to the table is that snapshot is the person at their most vulnerable in the hospital when they are physically suffering. And so if you think a picture is worth 1,000 words, then you can balance my snapshot against their experience. What I would most like is if we could all talk to each other, and that's what I've always wanted. And unfortunately, it just doesn't happen the way that would be at all close to ideal. And the sad thing is, I mean, we had another patient not similarly struggling, similar issues, not the same issue. And his wife came up to me in the hallway and she said, "Teresa, I feel like everyone knows something and they're not telling me." And no one should feel like that when their husband is really sick in the hospital. And I finessed it and said, "No, but he is very sick." And she said, I'm gonna be here for rounds tomorrow so I can talk to the doctor and find out what's going on. But the things that don't get said, people aren't stupid. They can see what's happening. And so my last pitch would be if we could just all talk to each other.
Okay.
Yeah.
Yeah, I was going to add to what Teresa said. The doctor sees actually a continuity over time, maybe years, maybe seeing the patient. But while the patient is in the hospital, it's the other way around. When I round, I will only see the patient for 10, 15 minutes, while the nurse is there for 8 to 12 hours with the patient. And so what we really need to do is to sort of blend these two experiences together to get the better picture of what we need to do with the patient. And as to the issue of the meeting of the minds I really think that there's ways to do that with the palliative care program. And what I tend to do is when I feel a patient is in need for palliative care, I have a conversation with the nurse and then get the nurse involved, and if there's an attending doctor, to get them engaged as well. And then you call a palliative care nurse in, and that end-of-life conversation really takes off with a palliative care nurse. The problem with palliative care programs is that 80% of large hospitals have a palliative care program, but they're not being utilized enough. And the doctors are often not consulting on them. And so I think those are the solutions towards where we should go, trying to use our palliative care programs more.
Some of the issues, challenges you brought up in your opening statements involved better training for doctors in medical school, I presume. Teaching them to have a willingness to have these kinds of conversations, possibly having to restructure parts of the healthcare system to allow people like you to have the time to do this. This takes a generation,
yes,
at least. So for the doctors who are in the pipeline, who are out there now, what are some of the shorter-term solutions you can think of?
Sure. There have been short training programs, 6 months or so, which have been done to see if they can bring about a change in physician behavior. And William Branch in Atlanta has done some of these programs to talk about issues related to compassion and end-of-life care. And what we find is we can change doctors' behaviors in issues related to compassion and end-of-life. Lots of times also, one of the programs being done for training is by the insurance company. Our malpractice insurance company is doing programs on teaching doctors on how to have better end-of-life conversations. And so setting up priorities through different mechanisms and getting the doctor's attention, I think, is going to be important.
Amy, did you want to jump in on that?
Well, I did, and I realize that language can be a barrier, and you are definitely a good person and on the right side of things. But I will say that ultimately, it's not for the clinical providers to decide when we go from preventive to curative to palliative. It is ultimately for the consumer of that health, the individual, their family. These are very complex decisions. They should be made in conjunction with their healthcare team. And I agree that it should be an open conversation between the entire team because people do have different information that can be shared. But ultimately, the decision about these choices and when we move or if we move into different modalities, that may not be the individual's choice. They may want to stay aggressive. But, more than likely, if they are well informed, they may not want to. If they're not going to have some real benefit from it, it causes real detriment to their lives. I've even heard, some of you may know that I also blog about all of these experiences on a health blog called Health Agenda. That's the Hartford Foundation's blog. And I get comments from people, including those who said, my family member went off to receive treatment that was not something that provided any value to them, and it only separated them from their family in their final days. I mean, some really tragic stories that are unnecessary, not just the pain and the suffering, which is horrible, but also the separation, the isolation. So they really have to be well informed. If there really is going to be benefit to their health down the road, that's great. But if there isn't, the decision has to begin with that individual.
Teresa?
Yeah, I wanted to, if I can try and tie both these threads together a little bit, that these conversations are incredibly time-consuming, and also we're all people. People are unpredictable. We've had patients who will say, I've had it, I'm done with this, and what they just need to be able to say that and have someone say, okay, you want to stop treatment? and then they think it through. And this is not someone who's at a crucial point. It's just someone who's fed up, who's sick of being in the hospital, who hates having us wake them up every 4 hours, in the middle of the night, who doesn't like being told 5 minutes before, get up, you're going to a test, and to have someone hear them and say, okay, you've had it, and then they think it through, and they're just annoyed. And then there's people who will have a very slow coming to terms with, wow, this is the end of my life. What do I want that to look like? And there are families who, when they're told there's nothing else we can do, will say, no way, that's wrong, there's got to be something. And we don't look at that as such a human reaction, because of course you don't want your husband or your mother or your child to die. Who's not going to respond like that? So the expectation that anyone can go in and tell people, okay, this is the end, and they'll, to pull out a Kleenex and they'll cry a little bit and say, thank you, I understand, is not a fair expectation. I mean, some people will react like that, but most of us are messy, and we're not. And so we all need to be given the time to listen and talk and let people find their own way.
Would you all like to join the conversation at this point? Do we have questions? If so, just raise your hand, stand up, identify yourself so the webcast audience knows who you are.
Thank you. I'm Joan Stanley from the American Association.
There's a mic coming your way.
Nursing. Should I
Sorry.
repeat that since we're being webcast?
Yep.
Hi, I'm Joan Stanley, and I'm Senior Director of Education Policy at the American Association of Colleges of Nursing. And I want to thank all of you for your very powerful and thoughtful statements and conversations. I wanted to build a little bit about the conversation that's gone on regarding educating or training healthcare providers. We have had what we call ELNEC, or End of Life Nursing Education Consortium, for over 10 years. And I think that nursing, we have a long way to go still as far as educating our future practitioners and our current practicing nurses. However, this consortium has been training, it's a train-the-trainer model, and it has been training practicing nurses, other healthcare professionals, and faculty for over 10 years, and it's now gone global. But I think this presents one model and an opportunity to extend that conversation to interdisciplinary or interprofessional model, and that I think we need to begin that interprofessional conversation at the very beginning while we're educating our future practitioners and those that are currently out there. So I put that forth as one model that has worked and that we can look to enhance or to extend this opportunity to create this training and to improve the care that consumers get.
I'm wondering how you know that it works, what your measures of success are?
Well, I hate to admit it, but I'm not the point person and the expert on our ELNEC conversation. But we have partnered with the City of Hope in Los Angeles and have created, we have excellent data on the number of individuals that have been trained from faculty to current practicing, information about changes that have been made in practice and thinking. So it has been a proven model, and it has now been supported, and they're doing training all over the globe. They're going to Romania. They've been in Africa and Asia and Eastern Europe and self-supported. The VA has supported them. So there is a lot of data that we could make available to the success of the training. And I think it's an excellent opportunity to make it an interprofessional model, because we need to have those conversations.
Is there another question here? While the mic goes over there, I will remind our viewers, our webcast viewers, that they can email questions, short questions please, at questions@aannet.org. Yes, sir.
Hi, I'm Jack Schwartz. I'm a law professor and former state government lawyer. Ms. Brown, one way to characterize your story is that it was a medical error, as much of an error as wrong site surgery or a drug overdose. Caused harm to the patient, harm to family, moral distress to the staff. If you were doing root cause analysis of that error, what are the systemic factors that contributed to it? And more importantly, what are the systemic changes that might prevent that kind of thing from happening again?
Okay, obviously this is a little bit of a sticky wicket, and I myself would never characterize this as an error. But taking that
Why
as
not? Wasn't it?
no, taking that as a thought point, the things that we've said here, that there's a reluctance to have these conversations. There's a tremendous pressure from training and daily practice to treat. It's very hard to tell someone who has young children that you're out of options. I mean, I think there are good human motives sometimes that keep people pulling everything they can out of the hat. And also just how fractured our care system is. And I'm not sure how aware people are of that, but this patient could have one doctor, any patient could have one doctor they usually see when they're not in the hospital, that they see at clinic. Then in the hospital, if it's a teaching hospital, the physician who's rounding, could be someone completely different, will be seeing them. Palliative care might be consulted. There might be other consults brought in. There might be an ethics consult. And then the hope of having that conversation can go up if you bring in ethics and palliative care, but it can also become less likely for the medical team to be on board, just because, it's like any problem. The more parts you split it, the more people you split it into, right? We're all not as good at talking to each other as we probably ought to be. So there just has to be a commitment from the top down, of saying what Amy's been saying. We need to give people their choices. We need to be honest with them.
Yes, why don't we stay over there as long as you're there? Sorry.
Thank you. My name is Mary Tinetti. I'm a geriatrician at Yale. My question is to you, Teresa, and I don't think you meant to do this, but you sort of paint the nurse's role as relatively passive in that patient that you talked about. And I don't think that was your point, and I understand how the dynamics work. But my question to you is, as an advocate, if you didn't feel you could directly sort of confront the patient and the family, at least it would seem, and you probably did this, but I think for the audience, I think would be helpful to present that the role that you actually have in encouraging the family to start the conversation. Because again, if we're all a team, anybody can start the conversation. It would be helpful, I think, to sort of convey a bit more how you could have a more active role rather than going in merely and causing clearly what must have been painful for you as well as for that patient and family.
Yeah, again, and every hospital is different, and I'm one nurse talking about my own experiences, so that should be clear. Definitely our role is to try and talk to the physicians, try and bring them around to what the family's going through. Are there really possibilities here? Could you have that conversation? I mean, Jackie asked me about that. Sometimes that will go over well, and there are times when it will not. So, in terms of initiating the conversation with the family, it's really not seen as it appropriately being my role to bring up that issue. It's really not. And, we could have a very long conversation about that, and I wish that it was. Even something like addressing code status. Does everyone know what code status, where someone says, do they want to be do not resuscitate, do not intubate? It really is the physician's prerogative. And I can keep my ears open, I can talk with the family, I can be there for them, I can hear everything they're saying, I can take any little glimmer of them wanting to have a conversation about it and have that conversation, but it is not, it's not my professional prerogative to initiate that. And, I'm sure there are other hospitals where that's not the case. It's just the way it is. I don't think it's that unusual that it's that way. But
Manoj?
Sure. So let me address that question from, again, physician perspective. I think we're talking about communication at different levels. So there's a level of communication between the doctor and the patient, and also there's a level of communication between the doctor and the nurse, all sort of focused in on this idea of end-of-life conversations. And clearly, as doctors, we have to take the responsibility at the step of talking to patients. Yet also, I think we have to lead a team where we have the nurse in those conversations. So when I did a conversation a couple of weeks ago with a patient and the family at the hospital, I brought the nurse in to be standing as a witness at times, but clearly to give her opinion on what was happening as well. In fact, having the conversation with the patient, even before that, I spoke to the nurse and got the opinion and see how the nurse feels as to what should be done. And often I've learned that this is so important. Even as a very simple, if you know what a Foley catheter is, it's a urine catheter. I'm an infectious disease doctor. And one of the things that we have learned is that if you can take the catheter out early, that it's beneficial to the patient because they don't get infected. And so in my orders now, what I have learned to write is DC Foley, if okay with patient and nurse. And so, I think those are simple skills that doctors need to learn, that it's not they alone who are going around making a lot of the decisions. There's a healthcare team along with, obviously, the patients and patients' families. That's a skill set. It's not something that you are born with.
I know there will be more conversation later about advanced planning, but I'm wondering, Manoj, do you find that when there are these kinds of communications with patients and their families, if there has been well thought out advanced planning, do the conversations go differently?
Absolutely. If there's been thought given to end of life before the patient comes into a crisis situation, it makes a huge difference. Mm-hmm. And that's why Gunderson Lutheran, when 90% of the patients have had end-of-life directives done, it makes a difference. And one of the things that I hear from doctors all the time is that, the patient's family want everything. Well, patients, they don't know what everything is, and they don't know what limited things are. I think we need to take the time to do it. And lots of times when busy doctors don't have the time, and I just tell the doctors, let's get palliative care involved to be with us, and let's begin the conversation. We don't make decisions. I don't like to make decisions on my first time with the patient, and just say, let's have this conversation another 24 hours, talk to your family members, and so forth.
Amy, I feel like you're sitting there thinking, I wish there were more doctors like this.
I'm very pleased with Manoj, and I'm very pleased with the oncologist who's been caring for me and the team. And I do have to share from my own experience. I went in and had seen the cardinal signs of what I had, and I told them. And there was a group of young fellows who came in the room, and they were just meeting me for the first time. They were being taught oncology, and the looks on their faces as they were doing the exam, and of course I already knew. I mean, before they were seeing the signs, I already knew. And they had these very distraught looks on their faces. They were communicating. I mean, they hadn't said a word, but they were clearly communicating. And I said, it's okay, you're going to go through this, but I want you to be able to talk about these things. You have to talk openly. This is what I have. And I started explaining it to them. We hadn't gotten the slides back. But, it's really important, if we want to get them prepared to be able to talk. I mean, they have to see how important it is from our perspective to have all the information. So I was reinforcing to them. It was a good teaching moment. But I would have to say kind of the construct of the team, to me, is not the doctor leading the team. There is a very interesting kind of confluence of members of a team, and I'm not quite sure how I would view it. But in this particular case, I would say ultimately they are all supporting an individual, however it is you want to configure that, and that person has to make some critical decisions. So think about it as kind of a CEO of your own health, and you have a massive team of experts and how they're supporting you and making really good decisions that are going to be changing your life from there on in, your remaining days. It's that critical. But I wouldn't say that any of those experts is the leader. Ultimately, we're in our bodies and we are making decisions that are critical to us.
But Amy, as I hear you speaking, you're such a capable, aggressive, bright woman. Not every
Nurse.
consumer and nurse, of course, is like that. And I keep thinking about those patients who are the scared ones, the vulnerable ones, the frightened ones, the ones who can't think clearly. Where are they?
So every month I go for an infusion
They can't
for
be
my
the
bones.
CEO.
I think that they can, or they have the ability to decide who they need at their side to
Okay.
help them become that
Okay.
CEO. I really think that they can.
Okay. Question? Yes.
Hi, my name is Joan Pankey, and I'm a palliative care nurse practitioner and a palliative care consultant and author. I just had a book, actually I received it yesterday, that I co-edited with another palliative care nurse, Patrick Coyne, and it's called Conversations. And we talk about communication, but it is a conversation, and part of that conversation is listening. And I think that's where a lot of putting the person, the individual, as well as their family, who are at the center of this experience, in charge. Whether or not it's that person or that family member that they're designating, or the friend, or whoever it is. One of the thoughts that Jack Schwartz had also was something about accountability, I think, is when you're talking about a medical error. It was one of the strategies I used in starting a palliative care service, is to actually make a medical error when the wrong opioid was used for pain management. And it actually started this trend in improving pain management practices in that hospital. I'm wondering about the panel, and it's not to one individual, of looking at accountability, or perhaps the word is competencies, in the training of individuals and having these conversations, in listening skills, and holding clinicians accountable for this type of treatment as well, which spans all, both preventative, curative, and palliative.
Amy and then Teresa.
So I have one comment. First, I just want to thank Teresa, because I think she is an absolutely brave and remarkable individual, and we will never get the perspectives out there until somebody is totally real and honest, and I am forever grateful to everything that Teresa does. In terms of it being a medical error, that would kind of rely on the notion that there is a standard of care. And the problem, the most fundamental problem, is we don't have standards. As I said, we've got better standards around buying a house and doing full disclosure. That's wrong. This is the most fundamental consumer protection that should be out there. This is just wrong. I would like to see ultimately it become a medical error. I'm completely on the same page. But at this point, there need to be some fundamental standards in the way in which this is addressed on a regular basis, so that it can in the future be an error when you don't do it.
Teresa?
Yeah, I'm thinking back to the issue of conversation and nurses' role, and there's been situations where I've had patients on a teaching service who, the scan came back, we got the result of the bone marrow biopsy, the news was not good, and the intern, the youngest physician on that team, would want to go in and talk with the family and tell them, and be told not to. And that would go all up the chain of command. So, we need to be reimbursed for having these conversations. We need to know how to have these conversations, but we also need to get over the idea that one person owns this conversation, and to have nurses or anyone. It could be the chaplaincy. It could be physical therapy.
Social workers.
Anybody, right. Introducing the idea of you're here, you're really sick, have you thought about what you want? You know, at the hospital where they do that, people are much better prepared, and the outcomes overall, personal outcomes, are much, much better according to the data that's out there. So it's having the conversation, it's being able to have the conversation, it's knowing how to have the conversation. There's a lot to it.
Well, I am afraid that we have run out of time for this conversation. I'm so sorry, but it is your birthday tomorrow, Amy. You get the final word, whatever you want to say. And then I'll turn it back to Jenny.
I just want to say that it's been a remarkable year, and it's because of the choices that I've been informed to be able to make. And I hope that you help support other people to be able to get the right to make whatever decisions are the right ones for them.
Okay. Thank you all so much. Thank you.
What an extraordinary panel. For our second panel, Jordan Rao will be our moderator, and it's my pleasure to introduce him. Mr. Rao is a reporter for Kaiser Health News, an editorially independent news service and a program of the Kaiser Family Foundation, a nonprofit, nonpartisan health policy research and communication organization based here in Washington, D.C. Mr. Rao reports about the affordability, efficiency, and effectiveness of the healthcare system with a focus on hospitals and other health systems and providers. His Kaiser Health News stories have been published widely in the New York Times, the Washington Post, the Los Angeles Times, the Philadelphia Inquirer, Politico, and on NPR.org and MSN.com, among many others. He came to Kaiser Health News when it was started in 2009 from the Los Angeles Times, where he covered California government and healthcare politics in Sacramento. Do you have stripes here for that, Jordan, on your lapel?
They're on my back.
You're on your back. He previously reported for Newsday in New York and the Concord Monitor in New Hampshire. Welcome, Jordan, and thank you for moderating this panel.
Thanks for having me. Where's everybody on the panel? If you want to come on up. I do a lot of stories on hospitals originally, and I've done a couple of pieces on hospice and on end of life. And we give some of our pieces to Scott Hensley, who's over at the NPR blog. He runs a really good blog. And I did one piece, and he called up, and he never calls up. He's just like, yeah, thanks, whatever, because he has to write like 10,000 pieces and just churn them through. And so he called. I was like, oh, what are you calling for? A mistake? And he said that the hospice piece that we had written had gone among the highest hits that they'd ever gotten. And I've sort of found one of the reasons I've been interested in this subject is because I find whenever I write a piece, there's a wide range of audience response and interest, and it tends to be very thoughtful for the most part, 80%, which is pretty good. So anyway, I think that there's a real interest out there among the reading public on the topic, a lot more than some of the topics that get covered a lot. Anyway, but you're not here to hear me, you're here to hear the panel, and we have a neat panel that's going to talk about some specific things that are going on in different places. So I'm going to, again, introduce everyone briefly, and then afterwards you can, if you want to see their longer descriptions, it's in your literature. We have Cinda Rustin, professor of nursing at Johns Hopkins Children's Hospital, and she's going to talk about end of life with children. And then at the other end of the world spectrum, we have Suzanne Prevost, and she is an associate dean at the University of Kentucky College of Nursing, and she's going to be talking about elderly patients. And then we have two people from two of the more interesting foundations in California. They're doing a lot of interesting work in financing different models, and they will be talking about their experiences. Kate O'Malley with the California Healthcare Foundation, which is based in Oakland, with a very tiny office in Sacramento. Used to be above my LA Times building. And Joseph Prevatil, who is president of the Archtone Foundation, and that's down in Southern California. So if you know California, it's very important to have a nice geographic mix so no one gets upset. So anyway, so Cinda, why don't you start?
So good morning, everyone. I feel like I have the privilege and the responsibility to bring the voices of children into this conversation. So I'm really here on behalf of more than 53,000 children who die every year in this country, and probably a very conservative estimate of about 10 million children in this country who have a serious illness. So as much as we would prefer not to talk about these issues in adults, take the magnitude of that and think about children. What would it be like to be the parent of a child who's just heard a devastating diagnosis? Who would help you to make those decisions? What would you need to help you and your family to be able to navigate through that experience in a way that you could live with, that you could, at the end of that journey, be a healthy family? How would you feel if those resources weren't available to you? So the issues that we're dealing with in terms of communication and decision making are intensified when you're talking about children. And children have cancer just like adults. Children live with chronic conditions like muscular dystrophy and sickle cell disease, and babies are born too soon. And so the opportunities to try to impact their lives are incredibly vast. One of those people was a young man that I had the privilege of knowing, Matty Stepanek. Matty was a young man who was born with a rare form of muscular dystrophy, and he died just before his 14th birthday. Matty was a really wise person, and I have to say has been one of my great teachers. But Matty said that palliative care used to be about helping children die, but in fact, palliative care is about helping children live well, and when we reach that critical point, to help them die gently. And I think one of the messages I want to bring today is that this conversation is about living. It's really not about dying. And if you spend any time in close proximity to death, as we heard this morning, it reminds us that the journey really is about living. And so children remind us of that day after day. And it reminds us of how incredibly challenging it is for families, for parents, to make decisions on behalf of their children. Children also have viewpoints. And Matty was an incredibly articulate advocate for himself. But I have to tell you that even with his incredible skill, he didn't always get the care he wanted in the way that he wanted. And so another challenge is trying to find the voice of children and how we actually respect them and involve them in these very difficult decisions. So programs like ours, the Harriet Lane Compassionate Care Program at the Johns Hopkins Children's Center, is like many, as I'm pleased to say, growing number of pediatric palliative care programs, where we provide comprehensive support for families during that journey of diagnosis and treatment. We work with them around decision making. We try to begin that process as early as possible from the time of diagnosis, and to help families as they deal with their grief and bereavement before the child dies and afterwards. We are very fortunate in our own institution to have a pediatrics at home care program that we partner with, as well as 2 local hospices. The benefit of that is we have the opportunity to give our families more options. But those features are still not enough, because the majority of children, 70% of children, still die in hospitals. We have to ask, is that the place where most children would choose to die? Most of them die in critical care units with tubes, sedated, and often separated from their families. So those are features that we need to really address, and our program has been working very hard to try to remove those barriers, to begin to change our culture in our institution that has been very resistant to the very idea that our efforts at the #1 hospital in the country might not cure or fix their problems. So we, like many others, are really looking at the state policy solutions. There are programs like the one in Florida where the entire state has come together to look at the all-inclusive program for children to remove some of those barriers. There's a parent-led coalition in California that has been incredibly effective in being able to bring awareness to the issues and the challenges that families face. One thing I know from working with children and families is there's a constant, and that constant is hope. We as the adults, and I notice there aren't any children in this room, are really the guardians of their future. And as a result of that, I think we have a responsibility to think carefully not only about our elders, but also the children who are really our future. To bring the voice of children into this conversation, I want to end with Maddie's words. Some of you know Maddie was a poet and a peacemaker, he would tell you. And he wrote this poem called About Hope. And I want to share it with you because I think it really gives us a bit of a roadmap. Hope is a garden of seeds sown with tears, planted with love amidst present fears. Hope is a rainbow of butterfly wings. Gently it beckons, lightly it sings. Hope is a present of future each day, a voice from our heart to show us the way. Hope is not passive, it's real and alive. Hope is a strength to guide choices made wise. Yes, hope is a garden grown for love and from tears, and hope which is nurtured survives throughout years. So my hope is that as we think about how we design a system in our country to deal with advanced illness, that we recognize children are part of that equation. They have unique needs, but they also have similar needs to adults. And it's really up to us to be the ones to paint the pictures of what those lives are like, to understand the challenges that families face, and the incredible resilience and strength that they bring to dealing with those challenges, and that they need a supportive community, not just clinicians, but broader communities to help them to be able to live as well as they can for as long as they can. Thank you.
Good morning. My name is Suzanne Prevost, and as was mentioned, I'm a geriatric nurse, so I'm here to speak on behalf of our elder citizens. As someone mentioned earlier, we have about 2.4 million deaths every year in this country, but 72% of those deaths are among people over the age of 65. And so this is a very prevalent challenge among that population. Also, as someone earlier mentioned, people rarely die where they intend or hope to die. About 20 or 30% of Americans die at home, although we've had multiple surveys that have told us that that's overwhelmingly the place where people would choose to die if they had the choice. About 50 to 60% of Americans die in hospitals, and an increasing number of Americans die in nursing homes. At this point, it's about 30%. If you're over the age of 85, it's more than 40% of those citizens who die in nursing homes. So that's been one of my challenges in recent years, is to try to smooth the way for elderly citizens in nursing homes who are at the end of their lives. So since a nursing home is such a common place to die, we have so many people who spend their last days in nursing homes, one might think that it's a place where staff are well equipped to support a patient through the dying process. And we would expect that since those specialists do so much of that type of work, that they would do it extremely well. And unfortunately, we have a lot of room for improvement in our nursing homes. And as a geriatric nurse, I don't say that to bash or criticize my peers, but I know that my peers are crying out for help to do this work better. They know that they could provide better care to elderly people. As a faculty member, in a prior position, I had a dual role where I worked with the Nursing Home Corporation. And I served as a consultant to the Nursing Home Corporation, taught their directors of nursing some courses and did some research consultation. And early on in that relationship, I said, what could I do with and for your nurses that would be most helpful? And they said, help us to help our patients die better. So a colleague and I started looking at that from a research-oriented, descriptive perspective and said, well, let's look at what's really happening with these patients who are dying in nursing homes within this corporation. And so we did a descriptive study early on where we looked at about 18,000 nursing home residents. And some of the things that we discovered were, first of all, that when you looked at those who died versus those who lived over a course of time, you really couldn't differentiate their care. The group of residents who died didn't get significantly different interventions than those who lived beyond the course of the study. And part of that, we believe, was because they weren't identified as dying. I think the providers had a hunch that they were dying, but nobody took a stand to say, this person is in an end phase, this person's dying. And so we thought that, if we could help these staff members to feel more confident in the prognostication process, particularly in nursing homes, it's very difficult with a patient with a chronic illness such as dementia. It's very difficult to predict how long a person's going to live. But we do have some data that can help us sort of inform that decision making about helping patients to have a better sense of how long they're going to live. And so that's what we set out to do with the nursing homes that we worked with. And so in terms of types of interventions that teams are using to support this population through this process, there are a variety, but I'm going to speak to some things that I've categorized into 3 different types of interventions. And the first is prognostication tools. In nursing homes, it's very difficult, as I already mentioned, for someone with a chronic illness, or in many cases multiple chronic illnesses, to have a clear estimate for how long they might live or whether someone's truly in a terminal phase. But several teams of researchers have been working on that issue, and there are data that can help support us in that decision making. For example, we have studies that tell us things like, if a person goes on dialysis, there's a 58% chance they're going to be dead in less than a year. And there are data like that about a number of illnesses that we can use to inform us and to help us make some of those kinds of decisions. The researchers at Brown University have done a lot of work along this line over the years, and they've come up with some specific tools that they're not perfect, but they're giving us more informed understanding of prognostication and how long we can expect someone to live when they're in an elderly end phase. In my own work, we found that the minimum data set, which is collected on all nursing home patients, really can be a very informative tool in terms of developing prognostication models and better understanding and better predicting how long a person's able to live, particularly in comparison to what I would call a gut clinical guess, which is what you get the bulk of the time. So the other problem, in nursing homes, people have a difficult time trying to understand how long a person's going to live, and therefore they don't know how and when to have these conversations with patients and families, or what the options are for people. But I think if we help them to make a better estimate of the length of life a person has left, then that can serve as a starting point to move people in the right direction in terms of the conversation and in terms of the intervention decision making. Another type of work that people are doing to try to support this population of patients, I put in the category of collaborative partnerships. And one group that I think does that particularly well is the team at the University of Missouri-Columbia. And I don't know if any of you caught this, but they had a new paper that just came out this week in JAMA. And it's a very instructional paper to teach physicians how to have this conversation with patients in nursing homes. The paper is jointly authored by a physician, nurse, and social worker, as is always the case with their team. They're very interdisciplinary in nature in the work that they do there. And the title of the paper is The Physician's Role in Patients' Nursing Home Care, but the theme of the paper is very focused on the interprofessional nature of the decision-making process and the fact that it is a process. It's not something that occurs at a given point in time that you fill out a piece of paper and the legal work is done, but that it's a very dynamic process that has to be fluid and change over time, particularly in this population. Another team that is doing some very impressive work along the line of collaborative partnerships is the University of Pennsylvania School of Nursing, and the partnerships that they've developed with Genesis Elder Care, working with, in collaboration with that group, they have had a long-standing project running where they have 3 arms of the project. In 2 nursing homes, they have control sites where people get a traditional process. In 2 other nursing homes, all the staff receive very specialized training in palliative care. And in the 3rd, they bring in an expert palliative care team to look over time at which of those support mechanisms works best to get the best decision-making process and the best outcomes. So the 3rd type of approach I'll talk about, I refer to as high-tech. One of the most fascinating studies recently, in my opinion, is work that came out of Mass General, where they developed a videotape to visually show patients and families what it looks like to pick different levels of care, whether you want aggressive life-prolonging care or a standard hospitalization without resuscitation, or if you want palliative comfort care. And they visually depicted what those scenes look like. And they randomized groups of patients and families, some to get the traditional verbal explanation of their choices, and the other group to get the videotape along with a verbal explanation. Now, when they compared those 2 interventions, the results were pretty dramatically different, albeit a small sample. Those that got the standard verbal depiction of what their choices were, 25.9% of them selected the aggressive life-prolonging care. But those that saw the videotape, none of them selected aggressive life-prolonging care. Likewise, 51% that had the verbal description selected standard care without resuscitation. In the group that saw the video, only 4% selected standard care. And in the group that saw the video, 91% selected palliative comfort care. So I think it's a great example of how we might use more creative technologies to help people better understand the choices they're making. Another high-tech type of intervention is the use of video phones or Skype-type technology to engage patients and family caregivers to interact with the provider team that's at a distance. So if there's a hospice service or a hospital service that's providing consultation, but they're remote from the patient and family, they engage those participants through these technologies. And in pilot studies of that work, again, coming out of the University of Missouri and partners from other institutions, they're seeing that the patients and families are more confident with the care that's delivered. They feel that pain is managed better, and overall, they're much more satisfied with the process. Finally, I have to mention sort of community-based programs, and I think a person that's probably familiar to most of you in the audience is Ira Bayak, who has done this in a couple different parts of the country in terms of aggressive community-based efforts to educate community-based consumers around the notion of end-of-life care and what some of those questions and decisions are. Finally, I have to brag on one of my students, who's one of my doctoral students, and I'm from Lexington, Kentucky. We have a Hospice of the Bluegrass is a very outstanding hospice service that we have in our region. Am I okay?
No, keep on going.
Okay.
Just knocking water over.
And all right. In the Hospice of the Bluegrass, one of the things that they're doing currently that I'm very favorable toward is sending advanced nurse practitioners into the nursing home environment to serve as a care manager for the patients in nursing homes that are receiving end-of-life care through this hospice service. And I think that, that's a higher level investment, but I think it really speaks to the complexity of that decision-making process, and that people in that situation, patients and families, deserve the highest level of care to help make those important decisions.
Good morning. I'm very pleased to be here to talk to you about a program that the California Healthcare Foundation is supporting in California, obviously, since this is where we work the majority of our time. And it's called the program Physician Orders for Life-Sustaining Treatment. And in your packet, you have a form, the pink form, and also a brochure that is designed for consumers to help them understand what it would be like for them to use this form, to have conversations, and to create a document that really captures the decisions they would like to make to shape their care if they have a serious life-threatening illness. And now that I've shown you the form, if you only remember one thing about anything that I say, and that's highly likely it'll only be one thing, this is it. It's not about the form. It's about the conversation. It's like Lance Armstrong. It's not about the bike. It's the same thing about Post. So, as healthcare providers and people in bureaucracies, as soon as you see a form, we have the neural pathways that tell us exactly what to do with the form. Oh, I'm going to fill it out. But you can't fill it out until you've actually engaged the person in a good, robust, detailed conversation in which they are fully informed about what it is they want to have memorialized on this particular piece of paper. And so that's really the most important piece. And when we hear about the Pulse form, where we say, yes, the form is important, but the conversation is the most important thing. So let me tell you a little bit about what we are doing in California. In 2007, we started with a small grant with a coalition in California to kind of stick our toe in the water around this particular effort. And we knew that our colleagues to the north in Oregon had been working on physician orders for life-sustaining treatment for quite a long time. And their original impetus in this area was a situation that we also saw happening very frequently in California. They were concerned about what happened to elders in nursing homes, as described so eloquently by Suzanne, who were transported maybe in the last year or 6 months or 3 months of life back and forth continuously to hospitals for some type of intervention, and then either sent back to that nursing home or to another nursing home. I myself have seen this in my own practice. In emergency rooms where a frail elder is on a gurney in the ER in a little hospital gown, and you just look and you wonder, what is this person doing here? I bet they came from a nursing home. And sure enough, look at the record and say, are there any advanced care plans in here? Does anybody know what we're going to do with this person? And there's no information. And so then the treadmill starts or the conveyor belt starts, and then the interventions start to pile on because the voice of the person and the wishes of the person were not available to really help guide that care and guide those decisions, and then care escalates. And I think anyone who's been in those clinical settings can foretell the outcome. And the missing piece, of course, is the wish of the person. So we started thinking about this at the California Healthcare Foundation. I work in an area called Better Chronic Disease Care, and our hope really is to become a catalyst and to set in motion types of changes in the healthcare system that will bring about lasting change to improve quality and, frankly, to lower cost of care. And providing unwanted care is really a very high cost in a healthcare system that can little afford it. So we started working with a small number of coalitions in California to see whether or not there was an appetite within the healthcare system to try to work with this new process, the conversation and the forum, and also to see what would it take for us to spread this throughout the entire state of California, which is 10% of the size of our country. In Oregon, it took them 20 years, really, to integrate POLST as the community standard of care. And California is 10 times the size of Oregon. So when we did the math, we're like, okay, it's going to take 200 years to do this as community standard of care, and we can't afford to wait that long. So with our coalition, we got together a task force of all the possible stakeholders we could think of in California who might have an interest in this. The California Hospital Association, the Medical Association, the Nurses Associations, the Nursing Home Trade Associations, the consumer groups, really a big tent. And with that process, looked at perhaps a coalition and our efforts in California would be best supported if there was some legislation in California that would make it okay for providers to honor this form when it comes in the ER. You can just imagine residents coming in ambulance companies with this form and the staff saying, oh, I don't know who this doctor is who signed this, out the door. So we wanted to make it okay for providers in the entire healthcare system to see a POLST form, recognize it, and be able to honor it. So in 2009, legislation became effective in California that limited or alleviated any liability from a provider if they honored this form in good faith, meaning that it had to be actionable, it had to be signed by the person and also by a physician, and it had to lay out the choices that they would want to have. So that was an important step for us in really reassuring providers that honoring something like this wouldn't cause them any difficulty in the healthcare system or in their own setting. The target audience, which sounds so terribly clinical, I'm sorry to say, people in California who would benefit most from this right now are people with serious chronic illness. And when we had to pick a place to start with, we decided that elders living in nursing homes were really a group of people who could really benefit from having this conversation and having this documentation available to guide their care. The other nice thing about the legislation is that it allows for this form to be honored across all settings of care. And the good thing about the POLST form is it is designed for portability. When I look at this form, when I'm really struggle hard, I try to think about, is there any piece of paper in the entire healthcare system that's designed to go across all settings of care? And I'm hard-pressed to come up with any. Even immunization records, every place you go, you have to bring your record and show you've been immunized here, immunized here, immunized here. But actually, the POLST form is designed to go across settings of care. And interestingly enough, it's the most complicated decision to have, and yet we're able to create a mechanism that hopefully carries that voice of the patient from one location to the next location. So our strategy in California was to have a state-level task force that really embraced this and would help us implement it from the top down throughout all the healthcare systems. Then we had the important piece with the legislation that really mandated it to be followed across all settings of care and relieved sort of like the concern about liability if it was honored. The third thing we did was in the state coalitions to have groups of people at the local level. So we worked with hospitals, we worked with nursing homes, we worked with EMS providers, we worked with hospice agencies in areas throughout the state at the implementation level, so they would really understand what it took to make this happen in their own community. And then the fourth thing that we did is we created and we've delivered a very intense education program for providers to really help them understand how to have the conversation and then how to make use of this particular form. And we have a Train the Trainer program in California, and we've trained over 550 professionals in California to do this work. The place where we haven't gone as intensively has been directly to the consumer. And strategically, and we can debate whether or not this was the right strategy, we really wanted to focus first on the provider community so that they would understand what this was and why it was important before we went to consumers. We felt that going to consumers first would create sort of a gap between professional knowledge and person knowledge. And a person might come to their doctor's office and say, oh, I really want to do one of these pulse forms, and then the physician or the provider might say, I've never seen that before, why are you interested in that? So we were concerned that we would get ahead of ourselves. So we started with the provider community, and now we're really working more on a much more thinking more carefully about how do we take this to consumers. And in the process, we did do this brochure, which talks to consumers about how to think about the value that this having a pulsed form and having the conversation with their healthcare provider might have for them. So the key issues that we have found in rolling this out in California, and I was really happy to be invited here to talk about models that work, because I'm track this very carefully in California, and some of the challenges that we see that have been reflected in comments of other people is that having this process really changes the culture of care because it forces has the potential to force communication in places where it doesn't already exist. So the first thing I want you to remember about what I say, and I'm going to challenge you now to remember two things. The first thing is it's about the conversation. Second thing is it's voluntary. You don't have to fill out a pulse form. And if you do, it is a process by which a careful conversation will help a person really understand what are the treatment options that I want to have and what are the treatment options that I really don't want to have. The difference between having a pulsed form and having an advance directive, and both are important and they don't cancel each other out and they don't substitute for each other. An advance directive names your proxy decision maker if you're unable to make a decision and may give some general guidelines as to what you might or might not want to have for treatment options in the future. It's great for everybody in this room. Speaking for myself, I hope to live for 25, 30 more years. I'm not going to know what the treatment options might be 25 to 30 years from now that I want to be specific about today. However, a pulsed form is designed for someone for whom you wouldn't really be surprised if they died in a year or two. So we probably know the treatment options and can explain them to them, that the decisions they might want to make in a year or two about tube feedings, about intervention, about antibiotics. And so for people for whom it's important to know the intensity of care and the decisions, they can do that now. For persons, most people here, it might be too soon to do a pulse form, although you could do one if you wanted to. The nice thing about a pulse form is that you can continue to have these conversations and your ideas about what you want can evolve over time. So this can change the culture of care because it requires communication in order for it to be done effectively. And these conversations, we know, don't commonly happen now. One of our challenges is engagement of consumers, and we're working with AARP in our stakeholder task force, with the assisted living groups in California in our task force, and we'll be developing more of a strategy to engage consumers more directly. Another challenge is preparation of providers. Other people here have spoken eloquently to that. And the way we look at the completion of a POST form is that it's the work of a team. And particularly if we're picking nursing homes as the place where we want this to be effective, if one takes a hard look at the presence of physicians in nursing homes, it's pretty scarce. And so to rely on physicians to be the initiators and the guardians and the shepherding of this process in nursing home is probably wishful thinking. Although the role physicians play in this is very critical, we educate the team in the nursing home to really understand the concepts and to help try to change the culture of that care. I think the other thing now that we're working very carefully and diligently on this in California, start to hear concerns and questions about the quality of the conversation, wanting to make sure that it is informed and people are aware of the impact of the decisions that are being made. And I was happy to hear your mention of the News Foundation video about decision making and showing pictures of people so they understand what does this decision mean. And they used exactly the same script with the pictures and without the pictures, and yet people made very different decisions. So knowing that, one of our community coalitions is using this video in nursing homes now to help support the POST conversation. So we're actually trying to bring in technology and new learning as well to really support patients and families as they think about these conversations. Do they really know the impact of the decisions that they're making, and how can we help them do a better job understanding that? And then I think the other thing that is really critical to be thinking about is the ownership of this process. And I'll end my comments with, you probably have heard this, and this is attributed to Charles Osgood, and it's an important job had to be done, and everybody was sure that somebody would do it. Anybody could have done it, but nobody did it. Somebody got angry about that because it was everybody's job. Everybody thought that anybody could do it, but nobody realized that everybody wouldn't do it. It ended up that everybody blamed somebody when nobody did what anybody could have done. So I'm adapting this for our work here today. Dr. Everybody in the ER with the patient at St. Somebody's Hospital was waiting for anybody to show up with a plan for goals of care and a clear conversation, but nobody talked to the patient. So I'm hoping that what we take away from this work today, both hearing from people who are impacted by these lack of conversations, the providers who are keenly interested in supporting these conversations, is that really it's everybody's job to help raise the voice and honor wishes of patients, understand and honor wishes of patients around the intensity of care that they would like to receive. Thank you.
Good morning. It's a pleasure to be here and to be invited to be a part of this distinguished panel of experts on best practices in advanced care planning and its importance as a public health issue. I never was technically very good. As a foundation leader, a non-practicing lawyer, and a former Jesuit, I bring a different perspective to the discussion. While there have been a number of approaches to advanced care planning explored over the past 2 decades, some of which have been discussed this morning, and I want to bring to the discussion is the importance of assessing patients' spiritual and existential concerns as they approach their end of life. I'm of the opinion that the best way to start any care planning conversation is to address one's spiritual and existential concerns and distress. In the next few minutes, I will provide an overview of Archstone Foundation's grant making to improve end-of-life care, identify those efforts we are supporting to further advance care planning, best practices, and encourage journalists and policymakers to reframe advanced care planning as essential to having quality health care, and thereby being respectful of patients' choices and honoring their dignity. As a background, the foundation is a private, nonprofit, grant-making organization committed to preparing society for an aging population. The primary foundation awards approximately $5 million in grants annually with a primary focus in California. Since the foundation's inception in 1985, end-of-life has been a grant-making priority. In 2006, the foundation launched an $8 million initiative to improve the end-of-life care for older adults in California. The foundation's strategies include education and training of nurses, certified nursing assistants, social workers, and physicians in palliative care. Second, we support demonstration projects to expand palliative care in hospital and long-term care settings. And finally, improving spiritual care as a dimension of quality palliative care. Archstone has supported several projects that promote skill building, demonstration of best practices, expansion of universal advanced care planning tools, and making healthcare whole by addressing the body, mind, and spirit. Regarding skill building, foremost has been the Foundation's support of the End-of-Life Nursing Education Consortium, ELNEC, and the lady, I think in the last row, spoke very eloquently of the subject. It's a train-the-trainer curriculum in palliative care. Nurses are primary providers of care to patients, yet many still don't receive the training to provide quality palliative care to patients. The 9-module curriculum emphasizes the importance of nursing care as it relates to patient communications, addressing spiritual and cultural needs, and answering legal and ethical issues. To date, 8,000 nurses have been ELNEC trained and are training nurses in their respective institutions. I'd also like to acknowledge Dr. Betty Farrell, who is the research scientist at the City of Hope, who developed ELNEC and is a contributor to the policy brief that brings us together here today. In regard to demonstration projects, the Foundation sponsors the demonstration project to test new ideas. The Go Wish cards developed by the CODA Alliance, initially tested with long-term care settings, facilitates conversations of values between patients, family, and providers. The playing cards with written statements prompt the patient to identify their values and is instructive in developing goals of care with family members and providers. Today, Go-Wish is being used in multiple settings and has been translated into Spanish. And I have brought some copies of these cards. Some of you may have them, some of you don't. They're both in Spanish and English. And if there aren't enough, if you just leave your card, I'll see to it that you get them. Specify English or Spanish or both. The Alliance for Living and Dying Well is a Santa Barbara County coalition of providers who are educating and assisting residents to complete advanced care plans using the tool 5 Wishes. The local hospital is scanning the advanced care plans into their electronic medical records. This project seeks to address the common challenge with advanced care plans. They are often not readily available in times of crisis and or cannot be found in a patient's chart. The Foundation is also supporting outreach to Hispanic older adults and their families to begin the conversations to complete their advanced care plans. And I brought copies of the 5 Wishes brochure, which accomplishes that. And again, they're back there. If there's not enough, I only brought a couple dozen. Your business card, we'll get them to you. Regarding universal advanced care planning tools, we all acknowledge a barrier to advanced care planning is the variable state laws that create, in my opinion, more confusion to the public and policymakers. To address the variability among states, Archstone Foundation, in partnership with the California Healthcare Foundation, has supported the American Bar Association's Commission on Law and Aging's web-based Universal Healthcare Power of Attorney form. Currently, The form is in its final stages and will be legally valid in 46 states. Please do not ask me why 4 states where the form was not valid are New Hampshire, Ohio, Pennsylvania, and Wisconsin. And I have no idea why they haven't accepted that yet. I could have seen some very small state like North Dakota or something that wouldn't have for whatever reason. But I really don't understand Ohio, Pennsylvania, and Wisconsin. It's a universal tool that promotes thought and dialogue about healthcare wishes and is an effective way to offer more individuals access to advanced care planning. Finally, regarding spiritual care, in February 2009, the Foundation, in partnership with the City of Hope and George Washington University's Institute of Spirituality and Health, GWISH, brought together thought leaders to improve the quality of spiritual care as a domain of palliative care. As a part of the conference, a working definition of spirituality for healthcare was identified, and I can tell you it was tortuous getting this particular definition. You can imagine having every religion there versus spiritual organization. But finally they hacked it out. It only took a day. Spirituality is the aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to self, to others, nature, and to the significant or sacred. I have tried to memorize that and can't do it. Also part of the conference was the identification of recommendations on how to improve spiritual care. Currently, the Foundation is supporting 9 hospitals that have hospital-based demonstrations that are conducting patient spiritual and or existential screenings and assessments, treating and documenting plans to address patients' needs and concerns, as well as measuring their impact on patients and families. Initial findings suggest that screening and assessment opens the door for even deeper conversations that inform a patient's goals and desires, and most importantly, their goal of care. Which returns me to my opening statement that without assessment and treatment of spiritual and existential concerns, even an ideal clinical plan will not address patient suffering and distress. In closing, as our country struggles with managing the rising costs of healthcare, and we strive to maintain our status as the provider of quality medicine, we need to revisit our values and make medicine whole. Not focusing just on the body or just on the mind, but all 3, body, mind, and spirit. This cultural change requires that we continue to do the following: educate and train healthcare providers to be compassionate and skilled in facilitating conversations. Educate the public about their right to choose and their rights to have their wishes honored. And in the inclusion of advanced care planning as part of all electronic medical records, so that anyone can express their wishes, have them documented in a manner that no matter where they are or where they access health care, they can have the confidence that their choices and dignity will be honored. I urge you to become more involved with all 3 of these 3 cultural changes. I want to quote David Stendhal Rast, who said, "Sometimes people get the mistaken notion that spirituality is a separate department of life, the penthouse of existence. But rightly understood, it's a vital awareness that pervades all realms of our being." I urge you to continue your compassionate care for patients and families and dedicate yourself to promoting cultural change. We are all here because we believe that as one comes to the end of their life, they should be treated with respect, dignity, and provided care that promotes the desired quality of life.
Great. I want to remind everyone that, and we can flash the address, there we go, for those of you playing along at home, send a short question question to questions@aannet.org. And then if anyone in the audience has questions, don't be shy about waving, throwing confetti, things like that, so that I don't miss you out of my peripheral vision. I wanted to start off with just the question that sort of popped in my mind. That was Suzanne, when you were talking about the video and you were giving off the responses, I think everyone was like, wow, that's amazing. So it sort of seems like, well, problem solved. Just show everyone the video. Can you talk about what type of resistance the video has and what type of efforts there are to use it and to send it out there?
Well, an interesting observation. I think where your head goes to with that is, oh, they must have shown something horrible, visually, and actually the participants who saw it, 86% of them said that it wasn't disturbing at all. It just educated them in terms of informing them about what the decision they were making. So I was kind of surprised to see that after seeing what the results were. I thought that they showed something very graphic that was just disturbing. Actually, you may know more than I do about resistance. You mentioned using the video as well in your region of the country. I really don't know if there's been resistance. I'm not aware that there's been any.
I haven't heard of any resistance. I know there's a great deal of interest in the healthcare community about the video. In addition to using it in our Pulse Coalition in the Santa Clara Valley, one of our palliative care consult teams in a large public hospital is also using it for educational purposes. So I think it's kind of a new thing. I've actually seen it. You could go on their website and look at it, and I found it interesting and informative. I can't imagine what would be the opposition to it. The creation of the script was vetted with many experts in the field, so there's nothing scientifically objectionable about the content of it. It's all based in evidence of what we know about what happens at end of life and who benefits from what kind of treatment and who doesn't benefit. And so from the professional community, I think that the writers and developers were very careful to make sure that anything that was depicted could stand its ground from a scientific standpoint. So I'd be curious to see where opposition would come from something like this. I think it's one of those things where patients and families involved in decision making, it's a teaching aid for them to help them. And so I'll keep my eyes out for who might think it's a bad thing, but I haven't heard anything yet.
And Jordan, I don't see that intervention as a one-size-fits-all, but I see it as more of a metaphor for looking at the problem in different ways in terms of using different types of approaches to deal with a difficult situation.
Great. We have a question from the internet for Cinda. Is special training available or being considered for end-of-life discussions specifically aimed for children and their families?
So it's a great question. As you can imagine, the conversations with parents about their children are very complicated and very emotionally charged. And so one of the things we've actually been working on in our own institution is we started our program thinking that we were going to begin with a consultation service, a more medically oriented consultation service. But what our community told us they needed was they needed some help in feeling confident and competent to have those conversations. So we began by creating palliative care rounds where people got together as the interdisciplinary team to talk about the challenges that they were facing with individual patients. And through that, we began to coach each other in how to frame those conversations. We also did have participated a number of times now in the Initiative for Pediatric Palliative Care, which is a curriculum that's very relationally based, and it is based on the notion of parents and professionals as partners in learning. So in that training, parents actually participate as members of the training group with the clinicians, which has been one of the most powerful teaching tools that we could ever find. It's very different to be in a training situation where a parent or perhaps a patient is present. It changes the dynamic, it dissolves the hierarchy, and we can actually talk to each other as human beings to human beings. And parents actually teach us a lot about how they want to receive information, how they hear the way that we phrase things.
One of my wishes is we would stop saying there's nothing more we can do, because it's actually a false statement. When we reach that point, there are many different things that we can do, but it is not true that there's nothing we can do. And so we've learned that in talking with families. We've heard from them how it's a process, and that it isn't a one-time conversation. And all of us on the team, and one of the things I think is unique about our program is that we began with the premise that everyone in our pediatric community was responsible for good palliative care. It's not just one person's responsibility. And so trying to think about where are the different openings, the nurse, the social worker, the chaplain, the child life specialist, who may be having a conversation with a child as they're playing in the playroom, and they start asking questions about, am I going to die? And really what they want to know is, are you going to be with me? Are you going to really be with me no matter what? Are you going to take care of my parents? Are they going to be okay? Because they protect often their parents because they see how much they're struggling. So the communication piece is huge, and it is a process that I think we are all trying to continue to refine. But certainly we have some strategies, and parents have been really instrumental in helping us to learn how to do that better.
Good morning. Thank you for your thoughtful comments on both panels. My name is Maureen Daly. I'm from the American Nurses Association. I'm an RN, Senior Policy Fellow, and the National Center for Nursing Quality. I'd like to call out two areas for emphasis that's been alluded to by both panels, but patient-centered care coordination. And nurses are leaders as well as other interprofessional team members in care coordination. And Amy talked about being the CEO of your care, but particularly in nursing homes where dementia is advanced at end-of-life care, it's very difficult for family members to prevent those unwanted transitions of care and to manage those transitions of care. So to that end, this week in testimony in front of the Office of the National Coordinator talking about data communication and care coordination, I used a specific example of a patient that went 2 days in a row to emergency room because supposedly low oxygen saturation levels. That was done incorrectly. She had a high level, 98% on room air, and they did the same testing in both emergency rooms and sent her back. But it was an RN case manager in that second hospital, 2 different hospitals, by the way, she was sent to, screaming, kicking, biting, having her family hold her down, saying, I don't want this. And it was an RN case manager that was called down because the staff nurse, the head nurse, the emergency room physician did not know if there was a geropsych unit that could better help manage the psychotropic meds that were causing her swallowing problems to get so much worse. It was finally called down an RN case manager who said to the daughter, the primary caregiver, you are your mother's advocate. You can go to the nursing administration and make sure that palliative care plan that you've checked off those boxes, which is just similar to the PULSE form, make sure that it's adhered to, and make sure your mother's wishes are adhered to. And I'd just like to also say there are 2 important levers that are occurring now, and that's meaningful use. And so that's why the testimony. We need to make sure that those advanced directives and the patient-centered care plan is electronically communicated across settings, and also involvement in the Measure Application Partnership. The post-acute care, long-term care will be putting recommendations for a coordination strategy for quality measures with 2 very important levers, public reporting and pay for quality. So pay attention to the work of that panel, and also make sure that they are including all the importance criteria, not the scientific criteria, but the importance criteria. What are the important quality measures in post-acute long-term care, palliative care, and end-of-life programs? Thank you.
If I could add something to your comment just a little bit. One of the things that our Oregon colleagues who've been in the PULSE world for a long time are working on now is an electronic registry of PULSE forms. And I think that that speaks a little bit to what, of course, the we're all interested in better communication. And their state actually funded the registry, and all post forms that are completed have to be entered. And then emergency medical services providers can call the registry and find out, are there any really orders that we really need to know before embarking on any care. So I think that that communication and the post-discharge and the continuity of care is really important, and information technology can be a player if we keep our eye on it and make sure we try to insert it every place we go, that this is really a key piece of information that needs to be available.
If I could just add that Janet Corrigan, the head of NQF, has said that data registries or clinically enriched data and care planning data are a bridge to meaningful use stage 2 and 3, when nirvana will come, where the clinicians will have all the data essential to calculate quality measures and to better care coordinate the patient-centered care.
We have another question from the ether, asking, and the first panel actually talked a fair amount about the payment incentives and disincentives to these type of discussions and decisions. And this question is, what specific things can insurers do, both public and private, to support these type of discussions and this type of a shift?
Well, I could just speak on behalf of children. One of the really difficult payment issues for children is the application of the hospice 6-month life expectancy criteria to children. Children rarely follow the rule books, and they're often very uncertain trajectories about predicting when a child is going to die. And so what happens is that parents whose children are continuing to receive high-tech care, because many of them need that to be able to be comfortable and to have a good quality of life, have to choose between having specialized hospice services and sometimes agreeing to do not resuscitate orders in order to preserve their ongoing shift nursing care in the home. And so those kinds of policy barriers, and the Program for All-Inclusive Care of Children is one example of a state waiver that gives more flexibility in designing programs that are based on what that child and family needs, rather than applying these sort of arbitrary criteria onto a situation where they don't really fit very well.
One comment that I would make on the insurer end is, I know that our experience in California is Kaiser is very interested in Pulsed, and I'm a Kaiser member, and I went to Kaiser, and I'm sitting there waiting, and I saw a Pulsed form in the patient education rack, and I was like, yes, penetration. But the nice thing about Kaiser in any organized healthcare system is they can make this an expectation of practice. I mean, it can be part of the requirements that they have of their providers, is that they have these conversations and they document these conversations. And I think Kaiser's created a way to capture this in their electronic medical record, and they make it an expectation of providers that they do this. They worked with the California Coalition for Compassionate Care, which is the grantee that we work with in California, to train in Southern California, I don't know, train hundreds of their healthcare providers, doctors, and nurses on having the Pulse conversation. And so I think that organized insurers have a leverage point that other people don't have in order to make this become important and provide the requirement and the expectation that this actually happen, and they are doing this.
We have time for a couple more questions, so if anyone has one, otherwise I'll just take them all for my greedy self.
Have you given any thought to some of the structural quality measures that need to be put in place? Let's give nursing home for a chance, where there's one RN to 75 to 100 patients, and the recent quality measure report that came out from NQF did not have any structural measures as far as staffing or skill mix, and how that impacts the quality of advanced care planning.
I haven't given that thought, to be honest. I think I think it's, in terms of staffing in nursing homes, there's some similarities to staffing in hospitals. There are a lot of other factors that go into the quality of care delivery in the nursing homes. I know staffing is a huge issue in most nursing homes. And yet, you know, I've had personal experience with some nursing home corporations that may have, Corporation A may have similar staffing to Corporation B, but yet is able to train and manage their staff in a manner that provides a totally different level of care. So I would be hesitant to move toward mandating a staffing ratio for nursing homes. I think the industry is challenged enough with some of the fiscal constraints to move in that direction right now. But I can certainly appreciate your thought and your concern in that direction.
The ANA does not support mandated staffing ratios, principles of quality nurse staffing, but you know, even culture is a structural support, a safety culture, and it can be considered to keep patients safe. An error or omission is not protecting the patient-centered goals, such as quality end of life. Mm-hmm. So an ethical culture for quality end of life, as well as the right mix of staffing and skill mix for care coordination for vulnerable populations, whether it be the frail elder or the end of life.
Great. Thank you very much. If everyone can thank the panel. Real quick, because I'm getting...
I just wanted to make one point there, that one of the most difficult issues, especially in Southern California, is the cultural issue, and what is ethical and appropriate in one culture isn't in another. You know, it's scary in California when you go to a public building and you find 9 different languages, you know, in giving directions. So the language issue, the cultural issue, it becomes more and more important, particularly in these big states where we have such huge immigrant populations. And I think, to answer the question of what's a big barrier in all of this, it's specifically that. And that's why the more we can do to translate into the other language, the more you're going to get the kind of results you want.
Okay. Well, thank everyone on the panel, and thanks very much.
Well, some summary thoughts and some takeaway messages here. First of all, I think our 2 panels were spectacular. I mean, I just think that we really got some great information today, and the questions from the audience and the questions from the ether were also very important. You know, I was listening and thinking all throughout this, and Amy, happy birthday. I think that her message, that consumers have the right to make their own decisions, but they don't know what their choices are. This message resonates throughout all of this. And so the importance of consumer engagement is so critical. And Teresa Brown saying, and her very vivid example, very disturbing example, that patients are often not the center of care, but they are the passive recipients of care, reinforced what Amy's message was. And in a situation like that, patient choices and decisions are impossible. And then Manoj Jain saying that proper physician-patient communications are not happening nearly enough. I mean, we know this, we hear this from many different areas, but when a physician who has a focus in palliative care tells us this, we need to listen. And the 4 reasons he gave are good theories as to why that is so. Cinda is a part of CTAC, and her message about children, and this is not being about death alone, this is about living and about hope. She keeps us on the right track with that message, and it's so important. And Suzanne Prevost, this idea, and I remember this from my AARP days, just seeing that more and more people are dying in nursing homes. And this whole area of prognostication is so important because it leads to the interventions that we need to focus on. Kate O'Malley and her message about POLST. I'm going to remember her one thing, which is it's about the conversation. We've got to engage the health consumer in order to fill out the form. It ain't the form, so much as the conversation. And then Joe Prevatil talking about something that tends to get lost sometimes in the shuffle, and that is the spiritual and the existential values involved. We live in a religious nation. We need to keep that in mind. That's critical to so much of what we're trying to do. So where does this lead us? What kind of takeaway messages can we think about? Well, here are mine. Number one, when we hear about how patients and their families have to fight their way through this maze of care settings and information and misinformation, we need a pledge. We need a Pulse pledge. And what it ought to say is, it doesn't have to be this way, and we're not going to accept it. And I can tell you that boomers aren't going to accept it either. Life is going to change around us, and we might as well be in front of the parade. Secondly, we need support for physicians and nurses and other providers along the lines that we heard about this morning: communications, pain management, and other education. Not just about patient care, but what is inappropriate care. And this idea about standards of care, I think, is so important. And somebody said, we need to teach listening as part of the rest of communications. And of course, we've known that. We've known that since 7th grade, and we need to practice it. Then the idea that there are clinical models, not just clinical models, but community models that work. And what we need to do is basically to document them where they need documented, and to promulgate them, and to take them forward. The next, I think, is the theme that maybe permeates everything today, and that is that the idea of consumer and patient involvement. It was the critical theme of the day. And first of all, when we think about advanced planning, I want to call attention to, in your packet, there is this call to action of CTAC, and in the middle of it is a continuum. And when we think about advanced planning, what we're talking about is getting right the part of the continuum where we need to focus. And it's persons with serious progressive conditions that limit daily activities all the way through to end of life. So we need to think about that continuum, and that's why advanced planning is so important. Welcome to Medicare. We need to get people thinking early. And of course, as Cinda has said, anybody can have serious illness. We need to get people thinking about choices of care in multiple settings. I mean, we heard that this morning. Nursing homes, hospital, home and community care, multiple settings. And so why do we want to engage the consumer? For that advanced planning, so that they can make choices about care when those choices come necessary. But there are a couple of other reasons as well, and one of them is to change the system. Consumers and patients can help change the system. Amy is changing the system as an educated consumer, as an educated patient. And when I heard Kate's story about Pulse, she said basically, we need to educate the providers first about this thing, and then we can go to the public or to the consumers. And it reminds me of the first program I ever worked on in public health. It was a National High Blood Pressure Education Program. And in the planning stages, there was a young cardiologist from NHLBI, and he didn't know social marketing or anything about any of that. He was a cardiologist, and he made a really fateful decision. And here's what happened. We had 3 planning committees. One was providers, one was patients, and one was the public. And the providers came back and they said, okay, we've looked at hypertension, and yeah, the evidence is now there. Now we know that if we treat hypertension, we're going to have an impact on morbidity and mortality. So here's what we're going to do. We're going to go out and we're going to educate the provider community, the professional community. It's going to take us about 10 years. And when we're done, we'll come back and tell you. And then you can tell the patients and the public. And Dr. Ted Cooper, this young cardiologist, said, the hell with that. He said, we're going to stress the system. We're going to tell the patients and the public at the same time, and they're going to demand treatment for hypertension. And I can't help wondering, and I don't want to disagree with an expert like Kate, but I can't help wondering if we need to stress the system. I mean, at least that's how I feel about it. And so my final takeaway is, Oh, and one other thing about why we want patients and consumers so much involved, because we need to change policies. We need to change public and private policies, and we need the public to help us to do that. It was for Dr. Jane's third reason. We need to change reimbursements and other aspects. And so if we get the public really deeply involved in this and engage the public, in addition to their own benefits, they can help us, I think, to achieve public policy change and private policy change. So my takeaway, what I'm going home with is, it's time. It's time. The panelists and many of you in the audience are clearly making a difference now. And so what I'm saying is, it's time to bring things up to scale. And my idea of scale is national change. Do this now on a national level. Thanks very much.
So we'll conclude the program this morning with just a few thanks. First to Bill Novelli for that excellent wrap, Bill, and also for leading us off at the beginning of the day. Thanks to the wonderful panelists. The panelists here and the prior panelists brought us rich and personal stories from the heart, as well as data, and both together are very compelling. As you've heard, the stimulus for the program was a policy brief from the American Academy of Nursing, and I would be remiss if I didn't briefly mention the excellent co-authors of that brief. They are Inga Corliss, Connie Dolan, Betty Farrell, Rosemary Gibson, and Judy Lenz. And finally, thanks to Diana Mason and Cheryl Sullivan for organizing this outstanding program, and to the staff of the American Academy of Nursing for support, and to the moderators that moved us along today. And getting waving from the back, I think thanks to all of you who have been with us for this crucial conversation, both here in the room and on the webcast. And thank you very much also to the Kaiser Family Foundation for hosting us in this conference room. This concludes the program. Thank you.